Hello. Today we're going to be talking about alterations in safety and security, specifically communicable diseases, infectious diseases, and integumentary conditions. We'll begin with communicable diseases. Rubiola, also called measles or the 7-day measles. Transmission is airborne. Incubation is about 10 to 20 days. The communicability, several days prior to the rash development to 5 days after the rash. Signs and symptoms. Initially, they'll have a high fever, lethargy followed in about 24 hours, cough, coryza, conjunctivitis, flu-like symptoms, and Koplik spots. Koplik spots are basically bluish-white spots and a reddened circumference in the mouth. So the acute phase, they'll have a red, flat rash, which appears about 3 to 4 days after the onset of symptoms. It lasts about a week, which is why they call it the 7-day measles. It begins behind the ears, spreads to face, trunk, and extremities. Nursing, they need to be in isolation, airborne isolation, until 5 days after they have that rash developed. Manage the temperature, keep the room dim. You want to clean the eyelids with a warm saline solution to remove any secretions or crust. You want to prevent the child from rubbing their eyes. A cool mist vaporizer may improve respiratory secretions. Petrolatum around the nares, keeping the head of the bed elevated. Cool liquids, small frequent meals of soft mashed foods, anti-itch medications. Avoid putting soap on the skin, using soft blankets. CPT as needed. Please note that vitamin A has been shown to reduce the morbidity and mortality of this. And it's really pretty high doses of vitamin A. Rubella, also called the German measles or 3-day measles. This is a droplet transmission. Incubation, 2 to 3 weeks. Communicability, 1 week before to 5 days after the onset of the rash. Signs and symptoms. Initially, it's a low-grade temperature, headache, sore throat, and cough. Acute, you have a flat red rash, begins on the face and spreads to the rest of the body. The rash lasts about 3 days, thus 3-day measles. It disappears in the same order of its appearance. Nursing, again, we're going to manage the temperature. Cool mist vaporizer can improve respiratory secretions. Head of the bed is elevated. Cool liquids, small frequent meals of soft smashed food, anti-itch medications. You don't want to put soap on the skin. A soft blanket, CPT as needed. Here you really want to avoid contact with pregnant women. And also for diagnosis, they will do a nasopharyngeal culture. Parotitis, also called mumps. The agent is the paramyxovirus. The source is saliva of an infected person. The transmission is a droplet or direct contact. Incubation is 2 to 3 weeks. Communicability is 1 week before and 1 week after the parotid gland swelling. So signs and symptoms. Initially, they can have a fever, headache, malaise for 24 hours, followed by an earache that worsens with chewing. Acute, swelling of the parotid glands. Typically, they reach the maximum size in 1 to 3 days. Management. As a nurse, again, managing the temperature, cool liquids, small frequent meals of soft mashed foods. You want to avoid sour foods, citrusy foods, spices, candies that increase salivary flow because that's going to actually cause more pain. You can use hot or cold compresses. If they have, for the males, if they develop something called orchitis, you can provide hot or cold packs for analgesia and elevate the scrotal area. Varicella, also called chickenpox. Here, the transmission is direct contact and airborne. Incubation is 2 to 3 weeks. Communicability is days before the rash to 6 days after the first lesions have crusted over. So initial signs and symptoms. Basically, they're going to have a mild fever, malaise in the acute phase, They have a very itchy rash that progresses from macules to vesicles, then they crust. Eruptions can last up to 5 days, and lesions of all types can be present at one time. Nursing, acyclovir may be administered to lessen the severity. IVIG or VZIG may be given to high-risk children within 96 hours of exposure. Non-aspirin antipyretics, calamine lotion topically for the itching. Oral antihistamines, oatmeal and Aveeno baths can also be very helpful for itching. You want to keep the nails short and discourage scratching to avoid scarring. Apply pressure versus scratching. Wearing gloves, especially at bedtime, to prevent scratching may be necessary. You want to keep the child cool because this can actually help decrease the number of lesions, lessen the pruritus. You want to keep the child occupied. If the crust is already loosened and it is irritating, those can be removed, but it's already like it's almost falling off. If a crust is attached to the skin, do not remove that. That'll result in scarring. And then again, as I mentioned before, teach the child to apply pressure to the itching areas instead of scratching it. And you want to keep them at home until all lesions are crusted. So when a child develops chicken pox, note that they then later are able to get shingles. And so if as an adult they have shingles, note that if a child is exposed to a person that has shingles and they've not had the chickenpox vaccine, they can actually get chickenpox. So remember, when people get chickenpox later on in life, they can get shingles or varicella zoster. Rye syndrome. We're talking about this because it's not uncommon to see that if somebody has chicken pox, we always say don't give them aspirin because they can develop Rye syndrome, and that's sort of why we're talking about this here. So this is an acute metabolic encephalopathy that can cause liver dysfunction. It does occur in 5 stages and has been associated with aspirin use. The incidence has drastically decreased since parents are aware that children with flu-like symptoms and chickenpox should not be given aspirin or anything that contains salicylates like Pepto-Bismol. Teach parents to avoid anything that has salicylates. It is treated according to the stage and the signs and symptoms. It is very important to do a good neuroassessment and accurate intake and output. So you've heard me mention a couple of times already using a cool mist vaporizer. Why do we use a cool mist vaporizer for children instead of a heat mist vaporizer? Basically, it's just much safer. We don't want them to get burnt. Pertussis or whooping cough. This is caused by Bordetella pertussis. The source, this is a discharge from respiratory tract of an infected person. Transmission is direct contact or droplet spread from infected person, indirect contact with freshly contaminated articles. Incubation, 6 to 20 days, but usually 7 to 10. Period of communicability, this is greatest during the catarrhal stage before the onset of the paroxysms. Clinical manifestations, well, prior to that, you want to obtain a nasopharyngeal culture for diagnosis. Now clinical manifestations during the catarrhal stage, so this is that early part, it begins with symptoms of an upper respiratory infection, such as coryza, sneezing, lacrimation, cough, and a low-grade fever. And these symptoms continue for about 1 to 2 weeks. Then they start to develop a dry hacking cough and it becomes more severe. During the paroxysmal stage, the cough is more common at night. It consists of short, rapid coughs followed by a sudden inspiration associated with a high-pitched crowing sound or a whooping sound. During the paroxysms, the cheeks becomes flushed or cyanotic, the eyes can bulge, the tongue may protrude. Paroxysms may continue until a thick mucus plug is dislodged. Vomiting frequently occurs attacks. This stage generally lasts anywhere from 4 to 6 weeks, followed by convalescent stage. Please note that infants under 6 months may not have characteristic whooping cough. They may have difficulty maintaining adequate oxygenation with the amount of the secretions that they have. They have frequent vomiting of mucus and or formula. The pertussis may occur in adolescents and adults with varying manifestations. The cough and the whoop may be absent. However, as many as 50% of adolescents may have a cough up to 10 weeks. Additional symptoms in adolescents include difficulty breathing and post-tussive vomiting. Therapeutic management and complications. So ideally, let's prevent this because we do have a vaccine for this. So maintaining current immunizations. Treatment, antimicrobial therapy like erythromycin, clarithromycin, azithromycin. Supportive therapy, hospitalization may be required for infants, children who are dehydrated, or those who have complications. They may have need for increased oxygen intake and humidity, adequate fluids, intensive care and mechanical ventilation may be needed for infants under 6 months of age. Some complications, pneumonia, and this is really the usual cause of death in your younger children and infants. Other complications like atelectasis, otitis media, seizures, hemorrhage, which would be in the scleral, conjunctival, epistaxis, pulmonary hemorrhage in the neonate, weight loss and dehydration, hernias, which would be your umbilical and inguinal hernias can occur, prolapse rectum. Complications reported among adolescents include syncope, disturbed sleep pattern, rib fractures, incontinence, and pneumonia. Nursing care. Here you want to maintain isolation during the catarrhal stage. If the child is hospitalized, they're going to be in droplet precautions. We'll obtain a nasopharyngeal culture for diagnosis. Encourage oral fluids. Offer small amounts of fluids frequently. Ensure adequate oxygenation during the paroxysms. Position the infant on their side to decrease chance of aspiration with vomiting. Provide humidified oxygen. Suction as needed to prevent choking on secretions. Observe for signs of airway obstructions like restlessness, apprehension, retractions, and cyanosis. We want to encourage compliance with antibiotic therapy for household contacts. Encourage adolescents to obtain the pertussis booster, the Tdap. Use standard precautions and masks in healthcare workers exposed to children with a persistent cough and a high suspicion of pertussis. Scarlet fever. So this is a group A beta hemolytic strep. This is usually from nasopharyngeal secretions of an infected person and carrier. Transmission. This is direct contact with an infected person or droplet spread. Also indirectly by contact with a contaminated article or ingestion of contaminated milk or other food. The incubation period is 2 to 5 days, ranging from 1 to 7 days. Period of communicability. During incubation period and clinical illness, it's approximately 10 days during the first 2 weeks of the carrier phase, although this can actually persist for months. So the prodromal stage, here they will have an abrupt high fever, pulse increase, which is out of proportion to the fever, vomiting, headache, chills, malaise, abdominal pain, halitosis, enthema, enlarged tonsils, edematous, reddened, and covered with patches of exudates. In severe cases, the appearance resembles membrane seen in diphtheria. The pharynx is edematous and a beefy red. During the first 1 to 2 days, the tongue is coated and papilla become red and swollen. So this is a white strawberry tongue. By the 4th or 5th day, the white coating sloughs off, leaving a prominent papilla or that red strawberry tongue. The palate is covered with erythematous, punctate lesions, exanthema, I can never say this word, exanthema. Here, the rash appears within 12 hours after the prodromal signs. Red pin-headed sized punctate lesions rapidly become generalized, but are absent on the face, which becomes flushed with a striking circumoral pallor. The rash is more intense in the folds of the joints, and by the end of the first week, desquamation begins. So you'll see a fine sandpaper-like the skin on the torso, a sheet-like sloughing on the palms and the soles of the feet. And this may be complete by 3 weeks or longer. They will be taking a full course of penicillin or erythromycin in children that can't take penicillin, or oral cephalosporins, antibiotic therapy for newly diagnosed carriers. So here they will do a nose or throat culture for positive for streptococci. Supportive therapy would be rest during the febrile phase, analgesics for the sore throat, antipyretics for the rash if it's bothersome. What are some complications? Peritonsillar and retropharyngeal abscess, sinusitis, otitis media, and then here you can see acute glomerular nephritis and rheumatic fever and polyarthritis. So we do want to institute a standard and droplet precaution until 24 hours after the initiation of the antibiotic treatment. You want to ensure compliance with oral antibiotic therapy. They may be given benzathine penicillin G by IM. You want to encourage rest during the febrile phase, provide quiet activity during convalescent period, relieve discomfort of sore throat with analgesics, gargles, lozenges. Remember, we don't give lozenges to children 3 and under because they can choke. Antiseptic throat sprays and inhalation of cool mist. Encourage fluids during the febrile phase. Avoid irritating liquids like citrus juices or any kind of rough chips. Once the child is able to eat, you want to begin with soft foods. Advise the parents to consult a practitioner if the fever persists after the beginning of therapy. And then you want to talk about how they can prevent the spread of infection. So making sure that once they've been on the antibiotics for a minimum of 24 hours, that they change their toothbrush and then avoid sharing drinks or food or sharing utensils. Next, we're going to talk about some other infectious conditions. The first one is enterobiasis, also called pinworms. This is the most common helminthic infection in the United States. The transmission is eggs can be inhaled or carried by the hand to the mouth. The eggs hatch in the upper intestines, and then the female lays the eggs out of the anus. The movement of the worms on the skin and the mucosal membranes on the surfaces cause intense itching. Pinworm eggs persist in the indoor environment for 2 to 3 weeks, contaminating anything they contact, such as toilet seats, doorknobs, bed linens, underwear, and food. Signs and symptoms: intense perianal itching. This increases at night, and this is really one of the principal symptoms. Evidence of itching in the young children can include generalized irritability, restlessness, poor sleep, bedwetting in a child that was not doing that prior to, distractibility, and a short attention span. They may also have perianal dermatitis and excoriation secondary to the itching. If the words migrate, then they can develop a vaginal and or urethral infection. Diagnosis is a tape test. Basically, you can get clear tape. You're going to wrap it around the end of a tongue blade with the sticky sides out, and that's going to be placed at the anus in the very early in the morning before they've had a bath and a BM. You want to leave it there for a bit, and then you will remove it, place it in a plastic bag or a glass jar, and then you're going to take that to the doctor's office. Know that this might need to be performed on 3 or more consecutive days before they actually collect the eggs. So treatment: parental pamoate. This is good for children 2 years and older, and they will repeat the dose in 2 weeks. Some side effects include dizziness, headache, cramps, nausea, vomiting, diarrhea. Albendazole, under 2, this is repeated in 3 weeks, or 2 may repeat in 2 to 3 weeks. So if it's under 2 years of age, they repeat in 3 weeks. If it's over 2, they may repeat it also in 2 to 3 weeks. Side effects here: abdominal pain, nausea, vomiting, dizziness, headache, ICP, increased liver enzymes. Know that this is more effective if taken with a high-fat meal. Pervinium pamoate, again, you need to have a repeat dose in 2 weeks. This medication can cause stool and vomitus to be a bright red in color, and it will stain clothes and skin. So please make sure that you let the families know that. And again, the dose will be repeated in 2 weeks. It's a very good idea. You want to treat everybody that is in the household at the same time because this is so easily transmitted. Wash hands before and after eating and toileting. Wash fruits and vegetables well. Keep hands out of their mouth. Do not share linens or towels. And please make sure you read the box related to intestinal parasitic disease on page 174 in your textbook. Impetigo contagiosa. This is a highly contagious skin infection, usually on the face, mouth, neck, hands, and extremities. This can be caused by staph, strep, or both. Signs and symptoms: burning and itching that develops into a reddish macule that becomes vesicular, which erupts and develops a honey-colored crust. The treatment, basically they're going to apply topical antibiotics of mupirocin or a triple antibiotic ointment for 5 to 7 days. Depending on the severity, they may need oral or IV antibiotics like penicillin if it's severe. If it's MRSA, they may need vancomycin. This is contagious until 48 hours after the antibiotics have been started. Follow-up: you want to make sure that the parents apply the medications as ordered. You want to soak and wash the area and remove the crust with an antibacterial soap and then apply the antibiotics. Wash all clothes and linens separately in hot water that the child has had contacted with. Please make sure that the family does not share towels with the child. Also inform the daycare so that they can sanitize all of the toys and surfaces. Dermatophytosis. These are fungal infections. This is also called ringworm. This is a fungal infection that is spread from person to person or animal to person. So you can see this in pets, like your dog or cat. If they have mange, that is also ringworm. So you can also catch this from seats with headrests as well as mats, so getting in contact with those. There's different types of tinnias, which are your dermatophytosis. So signs and symptoms: itching, circular patches, scaly and erythema areas. If it's on the head, the hair is lost in that spot. Treatment: antifungal creams times 4 weeks, 2% ketoconazole and selenium shampoo for 8 weeks. Oral griselfulvin for 8 weeks, and this should be given with a high-fat food to help to increase the absorption. Some side effects here would be headache, GI upset, fatigue, insomnia, and photosensitivity. Foot care: you want to keep the feet clean and dry, wearing cotton socks, shoes that are well ventilated. Let the family know that if it is on the head, the hair will grow back in 6 to 12 months. You want to pat the skin dry versus vigorously drying itchy skin. Vigorous drying can actually cause the itching to worsen. Scabies. This is a highly contagious infestation of mites, which is transmitted by prolonged personal contact. Here you will see a small grayish brown, thread-like, itchy black dot at the end of a burrow with an irregular rash. Distribution: generally in the crease areas. In children under 2 years of age, eruptions may be on the ankles and the feet. In kids 2 years old or over, you see it more on the hands and the wrist. A treatment, a one-time application of 5% permethrin cream, also called Elamite, for 2 months and over. You want to apply this after a bath, and it is typically left on for 8 to 14 hours, and then you wash it off. Often you'll put this on in the evening, and then they go to sleep, and then you can remove it the next day. All family members and others in close contact with the child should be treated at the same time. Again, you want to change the sheets, wash all the clothing, place any non-washable items in a plastic bag for 4 days. It takes about 2 to 3 weeks for the rash and the itching to disappear. Antihistamines and topical corticosteroids can be applied for itching. Alternative drugs include a 10% crotenmetone cream or lotion, or oral ivermectin for children weighing more than 15 kilograms. Pediculosis capitis. This is head lice. And so this is transmitted by a direct or indirect contact. Signs and symptoms is itching, nits stick to the hair shaft. So you can see like a little white dot, and you know it's not dandruff because when you shake the hair, the nit just sticks to the hair shaft. If it's dandruff, that's just gonna flake off. The bug is often not seen because they avoid light. They'll run from the light. The distribution is typically behind the ears, the top and the back of the head. The treatment is a 1% permethrin shampoo, also called Nix shampoo. Here you might need to repeat the shampoo in 7 to 10 days. This is contraindicated for those with allergies to ragweed or chrysanthemums. You want to remove the nits with a fine-tooth comb or tweezers, and to aid in the removal, you can use a solution of 50% vinegar and 50% water, and you can rinse that through the hair prior to using the comb. Follow-up, wash the clothes and bedding in hot water and place in a dryer for at least 20 minutes. It needs to be a very hot dryer. Thoroughly vacuum carpets, pillows, and furniture. If you're unable to do this, place the items in a plastic bag for 14 days. Lice will live for 48 hours off of a person, and then the eggs will hatch 7 to 10 days later. You want to soak combs, brushes, and hair accessories in lice-killing product for 1 hour or boil them in water for 10 minutes. You want to avoid using other people's hair accessories. Inspect children regularly. Please note that this is not a sign of somebody being dirty. This occurs in all socioeconomic groups, and this just can occur in any person. So please don't teach families that this has nothing to do with cleanliness. Next, we're going to talk about some skin conditions. So diaper dermatitis, here this is peak age is 9 to 12 months of age. This is more common in the bottle-fed infant than breastfed babies, and it's caused by a prolonged and repetitive contact with an irritant such as urine, feces, soap, detergents, ointments, and friction. So erythema is obviously a sign and symptom in the perianal region, and possible excoriation that can progress to macules and papules, which forms erosions in crusts. Moisture in the diaper area really create an environment that's favorable for a Candida diaper dermatitis. And so the Candida diaper dermatitis, here you're going to see really a very beefy red perianal area with satellite pustules. So you'll see these little red dots surrounding the main inflamed area. It is seen in up to 90% of infants with a chronic diaper dermatitis and should be considered in diaper rashes that are recalcitrant to treatment. It's really best to prevent diaper dermatitis. Keep the skin dry, use super absorbent disposable diapers to reduce skin wetness, change diapers as soon as they are soiled, especially with stool whenever possible. preferably at least once during the night. Expose healthy or only slightly irritated skin to air. We do not expose it to heat. You want to let the area just, dry out completely. Apply ointment such as zinc oxide or petrolatum to protect the skin, especially if the skin is very red or has moist open areas. Avoid removing the skin barrier cream with each diaper change. Remove waste material and reapply the skin barrier. To completely remove the ointment, especially the zinc oxide, use mineral oil. You do not want to wash the area vigorously. Avoid overwashing the skin. Also, you don't want to use like perfumed soaps or any type of perfumed or commercial wipes. These can be very irritating. You can use things like Cetaphil or a non-soap cleanser to wipe from the skin. You want to gently wipe the stool from the skin using a soft cloth and warm water. You do want to use disposable diapers, wipes that are detergent and alcohol free. So those are okay. Powders can help keep the skin dry, but talcum powder is dangerous if breathed into the lungs. Remember, if you're going to put any powder on a child, put it in your hand first and then apply it to the child. Plain cornstarch or cornstarch-based powders are safe. Anytime you're using the powder, as I mentioned before, you want to put it in your hand first. Store the container away from the infant's reach and keep the container closed when not in use. If it doesn't start to get better in 3 days, you want to notify the doctor because it may be a Candida infection, which can require treatment. And the typical treatment would be nystatin or clotrimazole. If you are using cloth diapers, you want to wash them in very hot water using mild soap and then do a double rinse using a 1/4 cup of vinegar in the last rinse. Atopic dermatitis, also called eczema. This is a chronic relapsing inflammatory skin disorder. It is especially occurs in families with a history of allergies and asthma. There's 3 forms. Infantile, this usually begins at 2 to 6 months of age and generally undergoes a spontaneous remission by 3 years of age. Signs and symptoms: exudative, crusty, papulovesicular, and erythematous lesions on the face, scalp, neck, forehead, arms, and legs. Note that this is very, very itchy. Childhood. This may follow the infantile forms. This can occur at 2 to 3 years of age, and about 90% of children with AD will manifest the disease by the time they're 5 years of age. Signs and symptoms: symmetric involvement typically, erythematous, dry, scaly, well circumscribed, papular, and more thickened and lichenified puretic lesions on the wrist, ankles, and feet, as well as the antecubital and popliteal fossa areas. Pre-adolescent and adolescent. This begins at 12 years of age, and this may continue into early adulthood or continue indefinitely. The signs and symptoms are pretty much the same as childhood eczema, but they can also develop very large plaques with thickened lichenified areas on the face, neck, back, hands, feet, and the upper arms. So the diagnosis is based on the history and physical and the presenting signs and symptoms. There are 4 goals of treatment. So 1 is to hydrate the skin. Using a tepid bath once or twice daily with no soap or very mild soap like a Dove or Neutrogena. Lubricant is applied while the skin is still damp. Oil or oleated oatmeal baths with a light drying may also be done. Glycerin-based lubricants like Eucerin, Aquaphor, and Cetaphil should be applied within 3 minutes of bathing at least 2 to 3 times a day. That basically helps to trap in the moisture on the skin. You want to avoid hot water because it is very drying to the skin. And then you want to use a humidifier to keep the skin moist. Again, pat the skin dry versus rubbing. Relieving itching, here you can do a colloid bath. Basically, all you're going to do here is apply 2 cups of cornstarch in a tub of lukewarm water. Remember, hot water is very drying. You also don't want to exceed 20 minutes because prolonged exposure to the water can also be drying to the skin. Cool, wet compresses also can help with itching. You want to avoid wool or constricting clothing because that can increase itching. Antihistamines such as hydroxyzine, diphenhydramine can be used, but note that those are sedating, so you might want to use those at night. Non-sedating medications like Claritin or loratadine or Allegra, which is also called fexofenadine, are preferred for daytime use because they are much less sedating. Wear loose cotton clothing, and take note, if there are certain foods that cause an exacerbation of the eczema, you want to avoid those foods. Also avoiding perfumed or scented soaps or lotions because that can also cause irritation. Reduce inflammation. So here they might be using steroid creams to diminish inflammation, and this would be applied prior to the lubricant. So you want, it's like having the medication directly on the skin. Do not use bath additives like baking soda, bubble baths, or bath oils. Preventing infection. So this is more due to the itching. So you want to keep the fingernails clean and short. Infants may actually require elbow restraints to prevent the itching. You can put cotton gloves or cotton socks on their hands. If they do develop an infection, they may need oral antibiotics. Reassure the parents that the lesions will not cause scarring unless a secondary infection develops or they are excessively scratching. Elidil, which is pimecrolimus, a 1% cream, or tacrolimus, which is a 0.3% or a 0.1% cream, is a topical immune modulator, and it's used to relieve itching and redness for children 2 years old and over. Some side effects include warmth and burning at the site, headache, cough, sore throat, and rarely viral skin infections. This is typically used for 6 weeks. If it's not effective, then it is stopped. This is only used when they have symptoms. So this should be stopped when the symptoms disappear. Acne. So this is a skin condition associated with increased production of sebum from the sebaceous glands during puberty. Acne is a disease that involves the pilosebaceous follicles of the face, neck, chest, and the upper back. There's 3 pathophysiologic factors that are involved in the development of acne. One is excessive sebum production, the next is comedogenesis, and then third is the overgrowth of the P. acnes. Comedogenesis results in open comedones or closed comedones. Inflammation from P. acnes can result in papules, pustules, nodules, and cysts. 70% of girls develop premenstrual flare-ups, which suggest a hormonal cause. Cosmetics containing lanolin, petrolatum, vegetable oils, lauryl alcohol, butyl stearate, and oleic acid can increase comedone production. Exposure to oils and cooking grease can be a precursor in adolescents who work over fast food restaurant hot oils. There may be an association with intake of dairy products and high glycemic index foods that might potentiate hormonal and inflammatory factors that contribute to acne severity. Treatment. The goal is to prevent infection and scarring and to decrease psychological distress. Tretinoin, also called retin-A, interferes with the development of microchromodones. You use this at night because it can cause high sensitivity to the sun. So you are at high risk for getting sunburn. So it is absolutely imperative to wear at least a SPF 15 daily especially when you're going outside. So basically, as part of your morning routine, you're going to want to put sunscreen on your face. When you're using the retin-A, typically this is going to be applied usually at night and you're going to apply a pea-sized amount of the medication 20 to 30 minutes after washing the face. This also will improve the penetration of benzoyl peroxide and topical antibiotics. So benzoyl peroxide, this kills the P. acnes. It can be used alone for mild acne. As the skin gets used to the medication, you can increase the strength. Please note that this will bleach fabrics as well as lighten the hair. Topical antibiotics, there's quite a few of them. Clindamycin, erythromycin, metronidazole, azelaic acid, and a combination of these can be used of either benzoyl peroxide and erythromycin, or benzoyl peroxide and glycolic acid. Please note, if they are taking oral tetracycline, you want to, again, avoid sun exposure. Oral contraceptives, this decreases endogenous androgen production and decreases the bioavailability of circulating androgens, which decreases acne. Obviously, this is for females only. Isotretinoin, this is used for resistant severe cystic acne, and typically they'll use this for about 20 weeks. This will decrease sebum production to almost undetectable levels. Note that girls should not get pregnant while taking this medication or for 1 month after the medication is stopped because of the risk of major birth defects. Girls need to sign an I pledge document. Some side effects include dry skin, dry mucous membranes, eyes, nasal irritation, decreased night vision, photosensitivity, bone pain, headaches, mood changes, depression, and suicidal thoughts. Patients receiving isotretinoin should also be monitored for elevated cholesterol and triglyceride levels. Dapsone gel 5% is effective for inflammatory acne lesions when used with topical retinoids. Here you're going to apply a pea-sized amount 2 times daily. Side effects: redness, peeling, dryness, may cause the skin to turn a yellow-orange color when used with benzoyl peroxide. You want to tell the patient that it may take 4 to 6 weeks to begin to see some improvement, and they may look worse before they see improvement because the skin is going to become red, dry, itchy, peely, and sort of burning. And then once that's done, they're going to see their skin is going to look much better. If they do develop scars, let them know that they can be fixed with laser treatment and light chemical peels. Teach the patient to wash their face twice a day with very gentle soap. Do not vigorously scrub. Avoid antibacterial soaps because they're just too drying in combination with the other topical medications that are being used. Also, avoid astringents because they are very irritating and drying. As difficult as it is, do not pop or pick at the skin. Avoid oil-based cosmetics and cleansers. Also, keep the hair off the forehead to avoid breakouts on the forehead, and make sure you keep the hair clean. This concludes this topic. Please make sure that you watch the other videos related to the objectives for this week. Thank you.